This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. So I want to go over some definitions. The third international consensus definition for sepsis and septic shock states that sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So what do we mean by organ dysfunction? It can be identified in a rise of 2 points or more in the SOFA score, which is the sequential organ failure score. We'll go over that in a minute. And if we don't know the baseline, because we don't know the patient, we assume it to be 0. We assume that they don't have pre-existing organ dysfunction. But if we happen to know that the patient had organ dysfunction, like renal failure, we would only look at the change of the score. We wouldn't give the patient any extra points because they came in with a pre-existing problem. So what we know is a SOFA score that rises over 2 reflects an overall mortality risk of 10% in the general hospital population with suspected infection. Even patients presenting with modest dysfunction can deteriorate further. This emphasizes how serious this condition is and how we need to implement prompt and appropriate intervention if that hasn't already been started. So here's the reference for the third international consensus definition for sepsis in JAMA from 2016. So in lay terms, sepsis may be defined as a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. This is a good way that I like to explain sepsis to family members at the bedside. Patients with suspected infection who are likely to have a prolonged ICU stay or to die in the hospital can be promptly identified at the bedside using the Q-SOFA score or the quick SOFA score. There's a 3-point scoring system which is super easy to use. First, you get 1 point if there's any alteration in mental status, and that's a GCS anything less than 15, even a 14. 2, if the systolic blood pressure is under 100, and 3, if they're tachypnic. So this score can be done in a matter of seconds right at the bedside without any testing. So let's review the definition of septic shock. Septic shock is a subset of sepsis in which underlying circulatory and cellular and metabolic abnormalities are profound enough to substantially increase mortality. Patients with septic shock can be identified with a clinical construct of sepsis with persistent hypotension that requires vasopressors to maintain a MAP over 65 and having a serum lactate over 2, despite having adequate volume resuscitation. If a patient was to meet the criteria for septic shock, their hospital mortality may exceed 40%. Let me review laboratory findings in sepsis syndrome. Patients may have leukocytosis or even leukopenia, or a left shift with more than 10% immature cells. In the response to endotoxins, there can be a bone marrow or a demargination release of white cells to help fight infection, or there can be sequestration of white cells in the reticuloendothelial system of the liver and spleen, and this can cause leukopenia. Activated white cells actually can adhere to the endothelium of the reticuloendothelial organs, like I mentioned, liver and spleen, and be taken out of circulation. We actually consider a leukopenic response to be a more serious indicator of sepsis than leukocytosis, because this is really an overwhelming response to infection, which is not a great thing to have. We see thrombocytopenia, platelets under 150, coagulopathy, rise of creatinine greater than 0.5, glucose over 150, bilirubin over greater than 4. These are routine labs. Now, we may be interested in checking some specialized lab. Although procalcitonin is classically associated with pneumonia, it's also elevated in sepsis, so it doesn't really localize the source of infection to lungs necessarily. Of course, if someone is septic and has a radiographic and clinical pneumonia and they have a very high procalcitonin, then we likely have good evidence confirming the source of sepsis is pneumonia. But remember, procalcitonin in severe sepsis is nonspecific and may not indicate pneumonia. We can have acquired adrenal insufficiency, that is an inadequate response of adrenal corticosteroid output during sepsis, which can contribute to shock. Most patients who are sick with sepsis, or for that matter, people that are just generally ill in the ICU, have a syndrome that's called euthyroid sick syndrome, very common in the ICU population. What we see in euthyroid sick is a hibernation type state. Patients will have a low thyroid level, but they'll have a normal TSH or even a slightly low TSH, so they don't seem to care. And there's no real reason to treat euthyroid sick. Obviously, patients with sepsis can have lactate due to inadequate tissue oxygen delivery. Elevated CRP is extremely common in sepsis, but entirely nonspecific. Any critically ill patient with any inflammation or infection is expected to have an elevated C-reactive protein. And finally, patients with sepsis can have poor oxygenation, a low ratio of arterial oxygen relative to FiO2. Anything under 300 meets the criteria for mild ARDS, or even worse as the PF goes down. We would not call someone with sepsis and a low PF ratio ARDS unless they had radiographic bilateral infiltrates in the absence of CHF. So I'd like to review the continuum of infection into sepsis and then septic shock and worse. So basically, any patient can develop an infection at any time, and just the presence of infection does not necessarily mean there's sepsis or shock or anything else. We have infections all the time. Infections can sometimes be treated as an outpatient, whereas septic shock obviously cannot be. As infections get worse, we may have a dysregulated response to infection with systemic inflammatory response syndrome, or SIRS. Classically, the presence of infection and SIRS together is sepsis syndrome. That's what we mean. It's infection with a unregulated host response to infection causing systemic inflammation. So that's what we mean by sepsis in the classic definition. Now, sepsis becomes severe when organs are involved. If you have end organ dysfunction, mental status changes, oliguria, etc., then we have severe sepsis. Or even lactic acidosis is usually proof of severe sepsis. Now, we talked about septic shock. It's a shock state with sepsis requiring pressors that persists after initial resuscitation. So this is a key fact in the case I presented. Just because you present with a low blood pressure does not mean you have septic shock. It's the persistence of hypotension after a fair resuscitation. We usually measure the resuscitation time as 2 to 4 hours. But for sure, after 4 hours of an adequate resuscitation, if your blood pressure is low and you have to start a pressor, you can officially diagnose septic shock. Now, the next step, if things get worse, is multiple organ failure. Now, as someone progresses through the continuum of sepsis, from a simple infection without sepsis all the way up to multiple organ failure, as things get worse, the obvious prognosis is worse. And the way I like to think of management of sepsis is that there are really only two outcomes. Once someone has severe sepsis, shock, or organ failure, we are worried that they might not survive. So there's a mortality risk. But on the other hand, we're hoping that they resolve their severe sepsis and multi-organ failure shock state. And there are actually, as you think about it, there's really only two things that influence which way this goes. There are host factors. So if you have a horrible host that has, it's actually three things. Host factors, if you have an immunocompromised host that's 90, even the best management might not save the patient. The second factor is the nature of the infection itself, and there's not much we can do about it. Some infections are more virulent than others. For example, overwhelming pneumococcal pneumonia with bacteremia is lethal even with the best management on a frequent basis. So after the first two factors that are out of our control, those were the nature of the infection and the host factor. The third factor is the medical interventions. And when we look at the three factors that determine outcome, poor outcome with mortality or good outcome, there's only one of those three factors that the medical team can influence, and that's optimizing medical management. And that's why, because there's such a high mortality risk as this goes down the list, it's critically important that we use optimal management strategies to give the patient the best chance at resolution. And that's what this talk is about going forward. So here's what we said. Patient factors and disease factors are out of our control. And treatment is under our control. So let's get more into SIRS. SIRS, as I mentioned, is a widespread inflammatory response to a variety of clinical insults. Syndrome is represented by two or more of the following: fevers or hypothermia, tachycardia, tachypnea or hypocapnia, leukocytosis or leukopenia with a left shift. This should be 10%, not 1%. Historically, this definition of SIRS was included in the definition of sepsis. As I mentioned, sepsis was defined as SIRS with infection or with suspected infection. But we've actually gotten away from this usage definition of sepsis. We have a more modern definition that involved a dysregulated response to infection. It's more of a vague response, and the reason is these are sort of arbitrary, and it's practically speaking, sepsis is still hard to define. So when you have an arbitrary definition, we may be excluding people that are clearly septic. We may actually sometimes be including people that are clearly not having an infection. So we basically have gotten a little bit away from this, but I still like to show the definition of SIRS, because when you see these types of clues, you should start thinking that your patient might have a dysregulated response to an infection or another insult. It doesn't have to be infection. It could be severe pancreatitis. Another thing we see is trauma and tissue injury. A crushed leg can cause SIRS. So sepsis, classically, sepsis syndrome in a classic definition was SIRS plus infection. And we already said severe sepsis has organ dysfunction. I mentioned that. Septic shock is refractory to an initial adequate fluid resuscitation requiring pressors. And the multiple organ dysfunction syndrome is, as this progresses, multiple organs sequentially fail, typically kidney failure, and then respiratory failure with maybe ARDS, and the other organs, liver dysfunction, bone marrow failure, encephalopathy, and even myocardial suppression. Every organ can get involved with multiple organ dysfunction syndrome, and there is a really, really rough rule of thumb. I'm not even sure how accurate this is, but I think it helps me understand mortality when I talk to families. Each organ that you count as failing adds about 20% to mortality. So once you have 3 or more organs fail, it's more likely that the patient will not survive than will survive. So it's a good rule of thumb. I would not, please don't quote me on that. It's just how I've always thought about multiple organ dysfunction syndrome. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.